So just want to start by talking about the situation we have around the world with the pandemic. And we're obviously handicapped because testing for the virus is only done in some locations, and particularly as the virus moves more and more through developing countries, we're not able to give really fully comprehensive figures on the actual numbers. Of course, the total recorded number of cases by testing is more than 5 million, but we believe it's many, many more than that. And having hoped that the situation would not be so serious in Africa, we're now recognizing that actually many African countries and their peoples are being affected by the virus, and it is unfortunately having bad effects as well. There is evidence now of new outbreaks starting in parts of China, particularly from the north, at the border with Mongolia and the border with Russia. There are reports that some of the people with COVID in that part of the world are not presenting with respiratory symptoms, but are presenting with gastrointestinal symptoms, which is a reminder that this virus is capable of presenting in a variety of different ways. That doesn't necessarily mean a mutation. It may just mean that people are responding differently to the effects of the virus. The other thing that's been reported, that's perhaps just because there are more and more cases being seen, is an illness with longer incubation and a longer duration of infectivity. That's come through from a number of different locations. The situation in children is still reasonably promising, although there are cases reported of extreme hypersensitivity reaction in children with a major organ failure. That is still relatively rare. So overall, under my first heading, massive risks associated with the virus, just to quote Dr. Tedros yesterday, we are in for a very long haul. It is going to be a long journey, and it won't be coming in waves. It's going to be a constant presence of a virus that threatens humanity. I'm smiling while I talk, I think because I like to smile in general when I'm doing anything, whether it's an interview or these briefings. But of course, I'm talking about something that's immensely serious and having terrible human consequences. And I'm going to talk a little bit more about those in a few minutes. But first, getting back to the vital steps that have to be taken in every community in order to stay ahead of this virus and to stop it from overwhelming health systems and harming people. It is about trying to make certain that the virus is just not able to spread from person to person. It's interrupting transmission. That's the only way to get on top of it. And that means finding people who've got the disease and isolating them quickly. And at the same time, finding their contacts or tracing their contacts and isolating them as well. And then protecting those who are most vulnerable. Why do I keep going on about this? Because I still fear that many governments and many people just haven't got that basic point about containing COVID, that it's about interrupting transmission. There are some challenges. If there are people with COVID who don't have symptoms, then frankly, it's really rather hard to isolate them unless you've tested everybody in the population. So having a very high index of suspicion about whether you've got the symptoms is so important. And that's where it's very interesting that this loss of a sense of smell, one of the earliest symptoms of COVID, really has to be taken seriously. And I'm seeing more and more governments recognizing that anosmia, loss of sense of smell, is a very important sign that should prompt people to go into isolation even before they get a cough or a fever or diarrhea or any other symptoms. Now, in order to get communities able to do this rapid isolation and interrupting transmission, there has to be a focus on making sure that all people know about COVID as much as possible. A mass public awareness campaign is an absolute necessity in all countries. And those countries that have informed their people fully about it in a very transparent way with messages from government to everybody in the community are finding that that does give better results. Some countries I find want to be a bit secretive, but I'm saying no, don't be secretive. Be as open as you can be. Be transparent in your communication, because in the end, it's only if people are empowered to make choices for themselves, weighing up risks in their own heads, that we'll be able to get properly on top of this. And so I keep stressing that community has to be at the center of the response. On the 15th of March, my colleagues and I wrote about this, and it's in our 6th narrative on our website. And it's about what happens at community level, community responses to COVID-19. And we said the most important first thing is to unleash local capacity. That's in making sure that people have the full opportunity to act for themselves in trying to make sure that transmission is interrupted. And then the second thing we said was activate networks. Go beyond the notion that basically it's the public health services telling people what to do, but work through community level networks, particularly networks that go outside the normal structures of command and control, and instead that empower people to be able to be active. Networks that involve business, networks that involve religious groups, networks that involve local community organizations, women's organizations, often some of the best networks that exist in any society. Work through networks. I'm going to keep on saying that almost because I think I'm kind of religiously committed to it, really, that working through networks is the only way to unleash local capacity. And so I ask all of you to work through your networks to help people to understand about COVID and to make sense of it for themselves. But of course, networks working on their own isn't enough. There has to be some capacity to coordinate what's happening in the different networks and to make sure that there is some degree of harmonization of what people are doing. That's why having a clear command structure that sets out the agenda is important. We rely on the public health services to do that, but then releasing all the different actors to be able to do the COVID action in their own ways, but coordinating as fully as possible. Like what we did on Ebola, where we emphasized the importance of having coordination capacity at local level, at national level, regionally and globally. Very open coordination structures is the key. So these are what I call the vital steps. And perhaps to just stress inside there, this practice of interrupting transmission through identifying cases and then requiring them to isolate properly, and then tracing contacts and requiring them to isolate as well. This is the absolute cornerstone. And I'm very pleased to see that in my own country, the UK, it has now been decided that that has to be done. I mean, I suppose what I'm going to say to everybody else is, don't wait several weeks before you put in place the necessary steps to get case finding and contact tracing in place, or what in the UK they call test, trace, and isolate. Don't wait several weeks to do that. Get that in place right at the beginning, because that's what you should be doing. Even when a lockdown is just starting, if you are using lockdown, use the time to build up the capacity for testing, tracing, and isolating. Or if you can't test, at least detecting people who might have COVID. That's part of what I call the vital steps, and it's my second item. Remember, my first was the massive risks associated with the virus. My second is the massive risk, the vital steps that have to be taken. My third item is just a reminder, I've said it before, but I want to say it again, is about false choices. It's not a case of public health or the economy. Again, looking at the UK and the US newspapers, but also sometimes talking to colleagues in India, I'm often asked, isn't it just so bad what's happening to the economy with so much unemployment, so many people poor and hungry? Isn't it time just to say, release the lockdown and let people get back to work? I said, okay. But if you just release the lockdown without putting your public health capacity in place, you would just get more and more outbreaks coming bounding back, and the health services will get overwhelmed. So my constant constant suggestion to everybody is don't see it as either or, see it as both and, both public health services at the community level, the vital steps like I just described, and at the same time, you try to release people out of lockdown as quickly as possible, remembering that lockdown is really bad for poor people. So it's not either or, it's both and. And then the other false choice that I'm often asked about is, aren't you expecting too much of people, to expect them to subject to surveillance to see whether or not they're ill? And aren't you expecting too much of people to accept them to put up with being isolated when in fact they need to be with their families? Isn't this undermining their liberties? To which I answer, if you don't have some kind of reasonably well-organized surveillance system in the community with full involvement of the people, then you're going to be really stuck when it comes to trying to ensure the liberty for people to travel, for people to see their families, for people to go and work where they want to. There has to be both surveillance and at the same time attention to civil liberties. And the two go hand in hand rather than being seen as an alternative. I suppose the reason why I get so frustrated about false choices is that in media, you get more readership if you can have an exciting headline that is always criticizing because somebody's gone too far this way or too far that way, too far for public health, not far enough for the economy, or too far for the economy and not far enough for public health. And yesterday I was doing a seminar with the Institute for Sustainable Communities with a lot of people from all over Southeast Asia, but also from the US, building a kind of network between themselves. And what was quite nice in that seminar was the acceptance by so many people that modern leadership is not about dealing with alternatives. It's about actually finding the way to navigate through complex situations and getting everybody to come to terms with the fact that there are trade-offs that have to be made in all aspects of life. And it's about finding the equilibrium that makes sense in your local community based on information about risks and opportunities. So let's try to shift away from these false choices or false dichotomies and approach the issue of COVID with a new style of leadership. So that was my third point, false choices. My fourth point, and perhaps my most serious point today, is what COVID is doing to reveal inequities. Now, I think everybody on this call is conscious that there are enormous inequities in the way in which we live in our modern societies. And to some extent, we get used to them. We get used to the reality that there are billions of poor people living in appalling circumstances in densely crowded settlements, in cities as varied as Manila, near where Joseph is, through to New Delhi, through to Cape Town or Johannesburg, through to Sao Paulo or Santiago. In fact, all over the world, there are people living in really substandard, in my view, accommodation, densely crowded settlements, very little facilities in the way of sanitation and water, very little space in their homes, and real difficulty with making their lives work, often having to take jobs in the informal sector and really hunting for money to make ends meet. We're just lacking all the kind of opportunities that we have. But I suppose that in a way, to cope with the fact that we're quite well off, we just try to perhaps ignore the inequities that exist. And we perhaps are not conscious of it all the time, that having all the clothes that we wear or the food that we eat at relatively low cost is because somebody else is working for next to no money in order to produce it and living in very, very difficult circumstances. But that is the way our world works. And what's COVID done? It's reminded us what's going on. It's reminded us about inequity. Inequity in the way we live, inequity in the way people work. And I suppose now is the moment for me to share with you some of the signs of inequity that I'm seeing all the time as I look at what's happening with COVID. And it's beginning to really hit me hard. And I'm not the only person. I was listening again to Tedros yesterday, to Carissa Etienne, the head of WHO in the Americas region, saying remember, this disease is hitting poor people really, really hard. And you don't have to go far to find this. I mean, who are the people who are most likely to get really sick and to die in Europe and in North America right now? It's this terrible acronym, BAME, Black, Asian, Minority, Ethnic People, higher death rates. Now, at first, I think it was thought that perhaps there was something about their genetic makeup that led them to be having worse outcomes. But more and more data, especially during the last week, is suggesting it's not that. It's that they're in occupations where they're more likely to be exposed to the virus, and their access to healthcare is much, much less. So in Paris, one of the big epicenters of the outbreak is in one of the very poorest parts of the city, where the majority of people are from ethnic minority groups. In US, most of the mortality is BAME, but there's plenty of evidence that they can, if they receive good quality healthcare, they can recover just as well as Caucasian people can. And then there's evidence from the UK that suggests that the reason why these people are getting more diseased is because of their occupations. They're more likely to be bus drivers, security guards, or working in essential services that have had to be kept going during the lockdown, but where it's impossible for people to do physical distancing. So let's remember that for many people, this is an occupational illness associated with poverty and associated with the conditions under which poor people are often having to work. So that's when we go into looking at the nature of the COVID outbreak in meat processing plants in the US, in Europe, and in other parts of the world. You may not know this, but meat processing is a highly automated business. And for those who don't really like hearing about this stuff, what I'm about to say may make you feel a bit unwell. What happens is the animals come in one end of the plant and they're killed, and then they're put onto conveyor belts. And these conveyor belts then take them along through the plant. It's cold, by the way. Just about, I think it's about 10 degrees Fahrenheit. I don't quite know what that is centigrade, but I was working on US data. It's cold, 4 to 12 degrees centigrade, says Florence. I'm going to introduce you to Florence in a second. So 4 to 12 degrees centigrade. So these carcasses are going onto conveyor belts. And then there are workers who then have to cut up the meat and turn it into what then becomes a little packet that people buy in supermarkets. Now, the meat plants all over the world have been increased in size enormously because meat processing has become much more centralized. So the plants that were perhaps built 40 or 50 years ago have been expanded hugely. More and more staff have been taken on. And in some places, the speeds of the conveyor belts have been accelerated so that they can get a higher throughput of carcasses. So the workers have to work faster, have to work closer together in order to try to process quickly. Why have the speeds of the conveyor belts been increased? Because there's been deregulation in the meat industry. Originally, in some countries, it was very tightly controlled by authorities who said you can only run a conveyor at a particular pace. But now it's deregulation, conveyors have speeded up. It's very hard for workers to be able to take breaks. Very noisy place, they had to get permission from a supervisor to go to the toilet or whatever. And if a worker is ill, they don't even have the space to protect themselves if they cough. And at the beginning of the outbreak in some meat plants in one country, they asked for masks, but there were no masks available. So they were told to work without masks. And then when the operators found they had big outbreaks, they were thinking they'd have to close down. But there was an order from the most senior person in the country saying, meat is an essential national security issue. You must stay open. So the workers were asked to continue working, despite the fact that in many plants, they had COVID outbreaks. Who are these workers? They're immigrant people. They're people who've come from all over the world. They're on very low salaries, but they're doing the job because they desperately need work. They often live in accommodation where it's extremely overcrowded. So this is an occupational disease of meat processing. And there are COVID outbreaks now in meat processing plants all over the world. But listen to this. Violeta Alexandra is the Labour Minister of Romania. She heard rumour quite recently that Romanian migrant workers going to work in meat.
I'm not sure.
Violeta, this Labour Minister from Romania, heard that meat processing workers had gone from Romania to Germany, and they got an exemption to the sort of lockdown and transport restrictions, that they'd gone to Germany and were working in meat processing plants in Munster in Germany, and there was a very large amount of COVID there. And she heard that the workers were not able to get proper protection from their employers, who were being told you still have to come to work even if you're ill. So this Labour Minister from Romania drives 18 hours from Bucharest to Munster, and she goes and tries to find out what's happening. She meets the Romanian meat workers who tell her that their working conditions are really bad. She meets the employers and asks them to create better situations for the workers. Then she goes to see the German Labour Minister, Hubertus Heil, and the German government yesterday issued a decree saying that the conditions for workers in meat processing plants in Germany must be improved immediately. And that's a very interesting outcome of the impact of COVID, revealing inequity, leading to action that could, I hope, start the process of a chain reaction of improving the conditions of workers in meat processing. But then, of course, the meat processors say, thank you very much. I'm afraid this is going to increase the cost of meat in supermarkets. And of course, then it gets into the next cycle of government saying, but people must have cheap meat. It's important. It's important for national security. It's important for their nutrition and well-being. And so I'm absolutely certain that there's going to be further pressure for the meat processors to try to keep the cost of meat processing down, to keep the price that they pay to the farmer for their animals as low as possible. And farmers are already complaining that they're not being paid even the basic value of the animal after it's been reared. And so once again, the desire for cheap food will lead to poor working conditions in the food system. That's just one small example of COVID revealing an inequity, action being taken, but will it last? And I suppose I've got many other examples now because I've been looking for them of where inequity does actually lead to greater COVID risk. And perhaps the most important of these is what's happening in India. I've been talking a lot to Indian officials and commentators about the situation that although more than half of India has absolutely no COVID, there is still a growing problem of COVID in very dense populations in Mumbai, in Ahmedabad, in New Delhi, in Chennai. And it's compounded by the fact that at the same time, they've tried to keep the markets open in some of these cities because poor people are saying, if you don't keep the markets open, we won't get food. And also our employment is curtailed. But it's turned out that the market in Chennai, which used to be called Madras, has been a major epicenter for COVID in Tamil Nadu, that's right. So the situation in India of COVID, which has got rapidly rising numbers of cases, is a problem in densely populated urban settlements, where it's really hard to do this business of case finding, tracing, and isolation. It's very hard to enable sections of the community to remain isolated. And people are really trying their best to comply. They're really adapting rapidly to physical distancing measures, but it's just super difficult to do so. And whenever I'm talking to my Indian colleagues, I'm saying to them, it is amazing what you're trying to do. Don't get disheartened that your case numbers are still rising. I think nobody has got a simple answer for how you deal with COVID in densely populated urban settlements where people are very poor. Just look at what's happening in Santiago in Chile, where the president has asked for there to be a very stringent lockdown because of the rise in numbers of cases. But people in the areas affected by the lockdown are getting really frustrated. They say they are hungry. They've anyway been unhappy about the conditions under which they live for many years. And so there is a big increase in rioting in Chile right now because of the impact of the lockdown associated with the challenge of containing COVID in the slums in Santiago. And that in turn will almost certainly create major problems for the government. It will certainly lead to violent repression. We've already seen it on videos, and our friends in Santiago tell us this is happening. But you can see how the pandemic and its impact in that city could well trigger major political challenges in the coming few days. But it's not just in Santiago. We've also seen it in villas in Buenos Aires, in favelas in Sao Paulo, poor areas in Ecuador, in Peru, and in Mexico. So all over the world, COVID right now is not only an occupational disease, particularly for poorer people, but also a disease for people living in dense urban settings. And of course, there's no simple way to deal with the problems of people having to live in slum situations. I mean, that's not something that's going to be resolved in the immediate future at all, despite anything that people like us may say about it. This is a reality of how the world works. But you can see how tough it's going to be for governments everywhere to be able to keep COVID at bay in these kinds of situations, which is why I do believe we all need to be ready, not only for a long haul, as was said in WHO yesterday, but for a really difficult series of challenges in trying to help people in urban communities, as well as people in low-income occupations to cope with it. I do think, by the way, that as well as physical distancing, we really need to be clear that face protection is important, especially if physical distancing can't be practiced. I was very pleased that the Spanish government yesterday said that people should wear face protection, particularly if they can't do physical distancing, especially if they're on public transport, not least to protect the workers who try to keep public transport going. And so it was a relief to me. I was just interviewed just now saying, wasn't that against WHO guidance? I said, no, WHO guidance is simply protect the very good, high quality N95 and FFP masks for health workers, because they are being put at huge risk as a result of their exposure. But face protection to reduce transmission, particularly if somebody's got COVID, doesn't know they've got it, or they've got COVID, but they're not able to take time off because their employer won't let them, they should at least be encouraged to wear face protection when they're up close. So I've said inequalities are revealed by COVID, and now I'm going to go lastly to the opportunities for change. I've identified for you one or two examples where I think by COVID drawing attention to poverty and inequity, there are opportunities now for people, particularly political actors, who really want to work for the poor, to do so now, and to perhaps be empowered by information that comes through from the researchers who are looking at the epidemiology of COVID in different populations, to the politicians then to take that information and really to advocate for better working conditions and better living conditions for poor people everywhere. After all, that is what public health is about. Ever since an epidemiologist called Michael Marmot did some work on the social determinants of disease, I mean, he wrote down, I think, what many of us had observed in our medical practice. He just made the point, poor people are more likely to get sick and to suffer and to die as a result of illness of various kinds, whether it's communicable or non-communicable, than better off people are. It's one of the core tenets of public health. And I think that we now need to be using the COVID lens to further reveal inequities in health but then trying to encourage good quality political action in order to look at the power structures that actually continue to sustain these inequities, and then to encourage changes that do improve the conditions for poorer people, whether it's living conditions or working conditions. And that is public health in practice. And that is what WHO stands for. So as I read comments from colleagues in WHO, particularly as they came out of the World Health Assembly, what they're saying is that the World Health Assembly resolution that was agreed on Tuesday, what it's really about is an equitable, people-centered response to COVID everywhere. That's not what's in the headlines in the newspapers, and we can talk about that later if you like. But what's at the heart of that resolution is that it's a resolution about equity, health equity, and action for health equity, which inevitably means engaging in the power structures that exist, but that's all right. That's what public health people always do and always will do, because that's the only way we can bring about real change. So those are my introductory remarks today. I hope that you found that interesting. I found it interesting thinking about it, because it's quite fun preparing for these online briefings. You're thinking, well, what are the issues that have really caught my attention in the last few days? And then trying to find a way to structure it so that it comes out in a reasonably coherent way. Well, that's what I've been doing, not only just before I went to bed last night, but this morning. And I really want here to give credit to my wife, Florence, because she has been in a very clear and coherent way, just reminding me at intervals during the last actually a few weeks, but it's been building up. Because of our work on food, she's an agronomist and she's worked on food with me since 2008. Because of our work on food, we've actually got quite a lot of understanding about some of the challenges in food systems and some of the issues that have developed because of the need for political need for cheap food so that poor people can eat well. But that has created all sorts of back pressures on food systems, pushing for greater efficiency, pushing for greater availability, whilst at the same time, obviously, there's a concentration of power in certain particular groups in the food sector, which inevitably mean that there are challenges in ensuring a just reality for smallholder farmers or for workers in the food sector. And even sometimes there are pressures that lead to the food systems encouraging people to eat food that are not necessarily nutritious or healthy. So that is part of the work we're doing in 4SD, is really campaigning for and acting for sustainable, just and healthy food systems. You'll hear more about that, I'm sure, in the coming weeks and months if you keep tuning in to 4SD. I'd just like to say that today people are connected from Nigeria, from Philippines, from Egypt, from Vancouver in Canada, from Singapore, from South Africa, from Kenya, from the United States, Switzerland, France, and the UK. We love this. Thank you. And I've left something out, sorry. Bangladesh. Hello, how do you do? Have you connected from Bangladesh? Oh, Shamim, you're there. Hello, sir. How are you doing?
I'm doing, and I'm really, impressed that you have raised this voice regarding this, slums people. And you know that Bangladesh has a very big slums and lots of poor people there. And it needs to focus on these issues because poor people are there and social distinction is really difficult for them because they live in one room with 7-8 people. So I think that is an important issue. Thank you, David.
Thank you, Shamim. Just for the rest of you, I've known Shamim as a real campaigning public health doctor for many years now, and I hadn't realized you were here. Thank you very much indeed for joining us. And thank you for making the point. So important. And I am grateful to you for being here. There are, I believe that there are some people here who who are quite young, as well as people who are at my sort of stage of life. Just want to say that one thing I really hope is that the messages that come through in these online briefings can reach younger people, particularly younger people who are working for public health, who are working for equity. I remember when I was in my teens, it was listening to people who, I won't say the names now, who would talk about these issues, whilst at the same time stress the importance of evidence when you want to bring about change. Perhaps the one person who had the biggest influence on me was a guy called Professor Archie Cochrane. And I'm just saying that because Paul Garner is on this call, and both he and I have been very influenced by the work of Archie. He worked with poor coal miners in South Wales, and that's how he learned his epidemiology and became a very strong activist for change. As well as Florence, who's sitting here and who plays a central role in organising these open online briefings. I'd also like to acknowledge members of the team, John Atkinson, Catherine Deland, Julian Delemontex, Thuy Nguyen, Magali Mahdi, Sabir Moumen, Joe Colombano. Now, Sabir is not here. He's in the midst of Ramadan, and during that time, he's got other things to do. And Joe Colombano is currently in New York, and I didn't think it was appropriate he should get up in the middle of the night. But everybody else, you just saw them briefly. Thank you for waving. A special shout out to Thuy, who makes these events happen and who manages the website and all the other things, wonderful things that you see there if you're following what goes on. Florence Egal, I see you're on. Thank you for commenting on Michael Marmot. I met him just the other day. He hasn't changed. He's just driven, that guy. He's really, really great. So Jane Badham, what are we finding in South Africa? Well, it's what we are finding in South Africa is a long delay between testing and getting results back. It's often taking weeks. It appears there's a shortage of reagents. Jane, thank you for making that point. I was actually looking into this quite recently. PCR testing requires many reagents, and some of them are really quite in short supply, as you've said, and because of the rapid expansion in PCR testing around the world associated with COVID, there is a shortage of two particular reagents. I've forgotten what they are. And there's no getting around this right now. And the challenge is that therefore, governments in South Africa and in many other countries are having to find ways of helping people to go through the process of identifying the disease through using symptoms and not just through using tests. Now, one of the challenges there is that there's worry at all times that there are people who are asymptomatic but have still got COVID, i.e. they've not got symptoms. I think if I was having a problem with delayed test results, I would do the following. Anybody who's got symptoms that might be due to COVID must be asked to isolate. And it's a difficult thing. It requires a lot of dialogue between authorities and people, but isolate on the basis of symptoms. And then if the test result comes back negative, if you're absolutely certain that that test was well done, then you can release the person from isolation. I've just seen some work this recently though, Jane, that says that actually there's in some places a 30% false negative rate for testing. This is results from parts of the US and also the UK. And so we must not treat the PCR test as an absolute gold standard. And I keep coming back to the symptoms. If a person clinically has symptoms that makes you suspect COVID, and I start with the loss of sense of smell, which seems to be an extraordinarily useful symptom. And certainly there's not many other causes of sudden loss of sense of smell. Secondly, the dry cough and a fever combination with a rapid fever. And thirdly, the more general malaise that comes with illness. I might ask if Paul's still on the call and feels like unmuting. If he wants to question my description of the symptoms, that's okay. I can't. Oh, there you are, Paul. I don't know, Paul. Paul, are you there? Yeah. Paul, anything else on the symptoms that you'd like to say? Because A, you work in the Cochrane collaboration, so me mentioning Archie Cochrane has meaning to you, but B, I know you're thinking about the symptoms of COVID right now. Would you like to make any comment about whether or not identifying people on the basis of symptoms is a reasonable thing to do?
I think it is if people listen to their bodies and ignore the algorithms. I used the CDC UK algorithm in the morning that I went into work and said, oh, I haven't got COVID, I've got a cold. I got into work and I just felt a bit strange, David, and it was actually in conversation with you, and you said, well, if anything makes you suspect, go home and isolate. And that's what people should do. It's pretty, and people understand and perceive the symptoms very clearly. So I think any degree of suspicion is very important. I mean, there's a pile of symptoms I could go through, but I think we should listen to people, and people should listen to themselves and what's happening.
Thank you very much indeed. Shamim, you want to do it? I'm just going to ask you to be super brief. If you want to say something, Shamim, just open your mic and say it now. Thank you.
Yep. David, you know that, in our country, the primary health care for the urban areas is responsible to the local government. But if you look at that, the structure, the service at this moment we are providing, that is through the health ministries. Local government are still behind the scene, and they may not understand what they have to provide the services, especially for urban slums people and other urban areas people. Other issues I like to raise that, in our country, around 5% people are going to hospitals for the treatment. The rest of them are staying at the home. But there is no mechanism to provide the services at the home. So what should be the mechanism for the services at the home level, especially for the poor people too?
Thank you, Shamim. I just want to say it's absolutely essential that in this particular situation, there is a build-up of local community level healthcare, if at all possible, and that all community health workers need to be given the basic protocols they got to work under. I would really agree with Paul Garner's point, and it's a tricky one, that actually we have to be quite broad in our understanding of what the symptoms of COVID might be. They're not always going to fall into a nice, neat pattern. Rojan, if you want to come in and just make any comment, please do so. I see Rojan, Dr. Rojan Dahal from Nepal. I don't need to open up your video because I know your internet connection is dodgy. Did you want to say something, Rojan? Okay, I can't hear you, so I'll move on. But if I do hear you, Rojan, I will. But Shamim, we'll have to try to have a follow-up conversation, probably one-to-one in the near future. Owen Gaffney said, do you have a view on the Swedish approach? There seem to be very poor outcomes in Sweden in care homes and amongst the Somali community in comparison with other Nordic countries. Well, some of you know that Sweden did not introduce any overarching requirement for physical distancing. It did not do a lockdown. And the epidemiologist who was in charge of the Swedish approach said, we don't need to because Swedish people are very good at physical distancing. They don't need to be ordered to do it. But the reality has been, unfortunately, that Sweden's got some really dramatic increases in the number of people with COVID and mortality. And the two groups that Owen's just identified, residential care for older people and in the Somali community. And yup, it's not turned out to be so good. I mean, it doesn't mean that I'm saying that lockdown is the only way to get physical distancing, but I do think that actually people need to be really strongly told that that physical distancing matters. And this is going to be a big challenge all over Europe as this clamor for releasing lockdown increases, which I quite understand. I think lockdown is terrible for societies everywhere. But, there has to be a contract between government and society. And the new contract is going to be physical distancing really matters. Facial protection really matters. Because when you've got a situation like happened in Korea, where they released the lockdown and then people started gathering in karaoke bars and they just have had huge new outbreaks. And so, I mean, it'll take time for people to make sense of this, but because COVID is not going to go away for the foreseeable future, physical distancing matters. So, Marianne, thank you for your question. I'm not going to do any more questions and answers live just for now, because otherwise I won't be able to get through everything, and I do want to cover everything. 293 organizations, 371 individuals wrote to Antonio Guterres, the UN Secretary General, and to Tedros, the Director General of WHO, supporting WHO and protesting the United States' use of the Global Humanitarian Response Plan to attack sexual and reproductive health and rights and abortion. How can we ensure that the pandemic doesn't become a political scoring point at the UN level to try to undo some of the gains that have been made, particularly on women's rights, as well as on sexual and reproductive health and rights? And it's more than just that. I'm afraid we're seeing the pandemic used as an excuse for denying other rights as well, and for various forms of oppression. And I don't have an answer, Marianne, and I know that you know that I don't have an answer. But goodness me, this is a time more than any where we need to be very vigilant at any effort to curtail people's human rights. And we need to be extremely clear in our articulation of that in whatever forums we can, using the power of social media, using the power of petition, using the power of movement to keep it going. And just everybody in all your networks needs to be on the alert. There is a real possibility in this pandemic that things that we've collectively worked for will be rolled back. And that may be to do with health, or maybe to do with food and nutrition, or other aspects of human rights. And Jane Badham's just come in. Jane, I can see your face on the screen there, and says it's so hard to apply self-isolation in so many of our contexts. And of course, in Singapore, where they've got a resurgence, I've said to you before, in the migrant home communities, we'll hear more about that later today. The situation there is that the way in which the government's done it is actually to require people not to self-isolate at home or in their hostels, because they're worried that that will just fuel further infection, but actually to come out and be isolated in specially created isolation zones. And the same's been set up in Kenya, but people are asked to pay for their own isolation, and they're not too joyful about that. And there are real challenges there, because some people say that to take people out of their place of residence and put them in another place to isolate represents a violation of their rights. And so we've got another of these difficult choices here. I'm not sure it's a false choice, but if you want to be effective in interrupting transmission, isolation really has to be not just self-isolation, but it has to be enforced isolation. And now another point from Jane. With schools reopening, I'm really worried that children will touch face coverings all the time and won't be able to keep them on properly for a school day, and therefore be at greater risk. What are my thoughts? I was just listening to Maria van Kerkhoven, of the technical lead on this WHO yesterday, and reading up a number of pieces about it. I just have to say that the role of children in spreading COVID is still not clear. Jane, you probably read that children don't seem to get most generally, severe illness. Very occasionally, there's this Kawasaki-like syndrome, but actually, I suspect that children are not getting ill as a result of the virus, even if they're infected. And the big question is, do children transmit it to adults? I think that basically returning to school has to be seen as an experiment. It's going to be difficult. I think you can't go on holding children back from school forever because of uncertainties. I think teachers have a really important role. My own view is that children, by and large, are able to become disciplined and to develop new behaviors. I think they're sometimes better at it than adults are. I think that we will learn with children about mask etiquette. After all, I've seen it in Southeast Asia after SARS, where children did wear masks a lot, that over time, children became more diligent about mask use and mask etiquette than their adults, and would often go home and tell their parents off if they were not masking properly, tell their parents off if they were touching their masks, tell their parents off if they were wearing their masks wrongly. So let's wait and see. At question 5 from Joseph Batak, if the world will be with COVID in the long haul, how long is the long haul? Until the vaccine is administered, or until the controversial herd immunity is in place? What scenarios are being explored? Joseph, I personally think it'll be a long time before enough people in any community have had COVID for there to be this magical concept called herd immunity developing. Herd immunity is when there's so many people who've had the disease and who've got a primed immune system that the outbreaks cannot spread. And that's because the pattern of spread of these outbreaks, they start small and focal and they build up quickly, but they can all be traced back to transmission via droplets, usually to one index case or 1 or 2 index cases. It's not an airborne disease that goes right across the population. So I actually am not anticipating that herd immunity will come anytime soon. And I actually do believe that this will be a threat until there's a widely available, safe, effective vaccine that's administered to everybody. I'm amazed by the speed with which vaccine candidates are appearing. But at the same time, I want to stress that in my judgment, it's 2.5 years before it will be possible for everybody who wants to be given the vaccine to actually be given it. And that's done hoping for the best. But remember that we've had scientists trying for more than 25 years to develop a vaccine against HIV, another RNA virus, not a coronavirus, and they've not been successful. So despite all these positive remarks and this desire by leaders to say, we'll have a vaccine by X, we'll have thousands of doses by Y, I just say, no false hopes, no over expectation. Let's just learn to live with this virus, all of us, for the foreseeable future. I'd like to thank Lucy Azikin, optometrist and NGO founder from Nigeria. Sorry, Lucky Azikin. Lucky, sorry for that. I'd like to thank Lucky Azikin, who will share his perspective in writing in reaction to this briefing. This is something that we've started and we're really enjoying it, that we're inviting people who take part in these briefings, not to write a record of the briefings, but just to write their feelings after they've heard the briefings and then to post them on social media. Just as we've invited people to develop videos or other things as a result of the briefings, just because we're trying all the time to stimulate a conversation and to encourage you to be in touch with us. To those of you who are in contact with us by email, don't hesitate to send emails. I know many of you are often in touch with us, or through LinkedIn. Prefer emails myself, but that's all right. Okay, so Chris Langton from Thinking the Unthinkable says, I mentioned the Somali community in Sweden. What is the current situation in Somalia on COVID? Well, on this call is Jo Nichols, or she's there. I'm not going to embarrass you, Jo, by asking you too much, but Jo, if you have the energy, just for 1 minute, could you say anything live about what you're picking up from tuning in, because you work for the United Nations in Somalia, based in Nairobi? Any quick 1 minute reaction, please?
Yes, certainly. There are over 1,500 cases at the moment, but it's growing relatively fast, and about 75% of the tests that are done are positive. So the sense is that the numbers at the moment are a massive underestimate. There have been quite a lot of deaths, and the sense is that that's because people are coming very late to hospitals and there hasn't been enough access to oxygen, and it's deemed that it's actually more about access to oxygen than something more complicated than ICU beds. That's the problem. But there's very little social distancing. There's a lot of effort to get messages out and to convince people, but they tend to have very large families, and families living in a big house, even if they're relatively well off, still have a lot of contact with other people. And then many people also live in much worse conditions, especially in some of the slums. And that means, and IDP camps. And that means that it's, almost impossible to social distance. There's a lot of work going on to improve access to water, to get people sanitization kit, but just keeping people away from each other, especially for things like burials. And I think for the upcoming weekend, especially for Eid, that's going to be quite difficult.
Thank you, Joe, very much indeed. Just want to stress that 75% of tests positive, in our judgment, means, as Joe just said, a lot more COVID than is actually appearing through the testing. The kind of figure you usually reckon when your testing is pretty comprehensive is about 3 or 4% positive. Also note the problem about access to oxygen. Thank you for pointing that out, Joe. The lungs get really stiff when you've got COVID, and the one challenge is getting enough oxygen into the body. WHO, this is question 7 from Rojan. WHO has endorsed traditional medicines that work. Do you think this is put at risk endangered species in the name of traditional medicine? Personally, I can't answer that question. And I'm not quite sure how I would, but Rojan, if I could just, because we're in contact on Skype, that's one I want to take and try to return to you later. I'm not sure how to say that. This is another question. You said we weren't looking at waves of cases, but a high caseload for a long time. Why do so many models still illustrate waves? That's because people have based their modeling on influenza. Coronavirus is nothing like influenza. Any control strategies that have been based on influenza are likely to be, sadly, very wrong. In influenza, you shift from containment to mitigation quite early on. For coronavirus, you have to be containing by interrupting transmission forever. And perhaps that's a good note on which to end. Again, I want to thank Tracy. Tracy, what's that? Come on, because Tracy says, my concern for children is the long-term effects on recovery of those children who contract the virus. You're so right, Tracy. Paul Garner, here on the call, has actually made himself quite famous because he's drawn attention to the long-term consequences of this disease, not just on the chest, but also on other body systems. And so are there any studies being conducted on the long-term conditions resulting from COVID in young children who have their whole lives in front of them? Yes, but I want to ask everybody to be alert for the possibility that we're going to see many more consequences of this disease in younger age groups than have currently been reported. Just keep an open mind. As I say to everybody, this virus is dangerous and it's surprising. So I'd like to acknowledge Florence Egal, who's been a fabulous colleague over the years. And I can see you sitting there, Florence, for your constant attention to issues around food and the relationship between public health. Thank you for offering to connect public health and food. I'd like to follow up with you. Florence, you can have the last word. But it requires me doing that, but yeah. Okay, that's not working, Florence. I'm not, okay. It didn't seem to work somehow. Yeah, Florence, just, it's not working. That's why it keeps going off and on. So if you can come on next time.
Is it better now?
Yeah, you're on.
Yeah, it seems it's not going off again. Yeah, I think there is so much going on. I know, for example, this afternoon, there's 3 webinars at the same time on related topics, related to food, to resilience, to urban-rural linkages and so on. And it's a full-time exercise just to try and serve those, to figure out what's worth doing. What I'm, as you know, David, I've always been concerned of the institutional gap that has developed over the years, and we're all trying to fight between food and health. And I think COVID is particularly, it really should be an opportunity to try and get around the same table and move forward, in particular territorial level. So if there's any way I can help, I'm on Zoom from, well, for the Pacific, it ends up at 1 o'clock in the morning, but it starts in Australia really early. So I think it's really, I'm very, very interested in seeing how I can connect and be of any help just to share the information of people potentially interested, because the managing and preventing and lockdown and isolation, etc., is having such an impact on food systems. And we are already, I think in a few months' time, we're going to find terrible increases in malnutrition, and we need to prevent this. Thank you, David.
Thanks very much, Florence. Just a quick note to Iman Ahmed. I'm going to, in the next session, at your request, Iman, you must tell us which one, whether you're going to be on next Tuesday in the evening or Thursday in the morning. We will talk about herd immunity. I thank you for asking that we cover that. Well, I'm just so pleased that we've connected with people, particularly colleagues that I worked with years ago that I wasn't expecting to see. I'd like to thank all of you for joining, and I'm really, really keen to sustain this approach. We will go on doing it, and I just see Owen. Just Owen, is it Owen who's got his hand up? Is it Owen?
Yeah. Hi, David. Actually, it was the question earlier on Sweden, which we answered excellently.
Thank you, Owen. I'd just like to say we will keep doing this. Do encourage your friends to join if you find it useful, and let us know if there are ways in which we can make this more helpful. I'm really wanting to give a special shout out to Florence, Florence Lasben, who is actually empowering us. I hope she'll come and just stand next to me for 2 seconds and say bye-bye. Thank you, everybody. Have a good rest of the day. And that's the end of the broadcast, but I do want to find my daughter. Thank you, Joe. Thanks for the wave. Thank you, Shumim. And there is my grandson, Isaac. Thank you, Isaac, for joining these things so frequently. I hope you're finding them useful for your public health education. Yeah. Thank you, Polly, for being with us. It's great. Hello, Jane. Nice to see you again. Bye-bye. Bye-bye. Shamim, it was great you were with us. Sarah, thank you for joining. I'm just so grateful to you for sparing the time. There you are. How do you do? Marianne, thank you very much for being with us. It's lovely to see you there with your smile. It's great. And then Iman, it's lovely that you join regularly. You must always tell us whether you find them whether you find that they add to your understanding. And also, if you think that I've got it wrong, anytime say so. Magan Mutefa, nice to meet you. I hope you're good. Rojan, we will have a follow-up on the traditional medicines. Tracy, hello, how do you do? Nice to see you again. Gosh, it must be quite late. It is late. Thank you for joining late in the evening from Vancouver. It's just so nice. Thank you. Chris, and I'm glad that you're with us. And thank you for the Thinking the Unthinkable effort. Sanjukta, nice to see you again. Christian Lara, I did say we would connect in the webinar that you've proposed. I hope we'll make that happen. Lucky, there you are. Great to see you, Lucky. And thank you for all you're doing. And keep pushing us if there are things that you feel that we must do and do more of, or places where we must be more active, particularly in the WHO scene or in the UN scene. We'll do what we can. Okay, I'm now going to slip off, not because I want to go, but Dara, thank you very much indeed. Bye. Only because the next thing is starting up shortly. Okay, bye-bye.